Hey guys, listen, I wanted to give you a little bit more knee anatomy, and I thought we'd go through this image here and talk about knee subluxation or floating kneecap as it in respects to the mechanical congruency, mechanical strength of the knee. And we look at this on the left-hand side here, on the far side of your screen. We have a nice well-attached kneecap. We have a nice attachment down here. So this is our patella tendon here, all the way down here, attaches on the tibia, and of course this is the patella bone here, and this is of course our quadricep, femur, and of course again the tibia. So this is a nice attachment. Now, when the quadricep muscle contracts, remember we talked about in the other video, when muscles contract, they contract up towards the spine. It's going to shorten and pull this way, which of course in effect extends the knee at the tibia because that's where the attachment point is. So everything kind of moves on this plane of action, nice and vertical. The kneecap sits on a series of grooves and it runs along these grooves. It kind of keeps the kneecap in place. And as long as the muscles are all around on either side of the kneecap here, so the vastus lateralis, the intermedius medialis, and rectus femoris, as long as all these muscles, the four quadricep muscles, are strong and in tune and they're firing or they're reacting the way we want them to react, the pull on this tendon will be really symmetrical. But if I'm really weak here, and this is my vastus medialis, this is the inner thigh muscle, and if you see, look on bodybuilders, there's that teardrop on the inside of the knee. That's kind of an exaggerated view of that muscle. So this is really weak, and it is for the vast majority of the population. And we're really tight here, and we're really dominant here. The kneecap probably doesn't track quite the way we want. It doesn't have that vertical tracking mechanism anymore. Now it's actually starting to go a little bit off to the side. And of course, that malalignment moves that kneecap out of the grooves that it's supposed to run on and starts moving it, kind of slides into the grooves. It starts running on the grooves rather than in the grooves. And then we experience something like we call patellofemoral syndrome, that inflammation underneath the kneecap. So when we talk about floating patella issues, floating kneecaps, there's a few different things that can cause it. One is trauma, so actually acute trauma to the knee, which really wreaks havoc with the ligaments and tendons in around the knee joint, and all of a sudden we lose the stability of the attachments that actually help control the knee joint itself, and the kneecap just kind of floats around a little bit without enough control to hold it into place. So trauma can set it up to create the floating kneecap issue and phenomenon. Also, it can also be congenital, where the attachment point, if you notice here, the attachment point is nice and vertical. We may have more of a medial or a lateral attachment point where the patella tendon doesn't sit here. It's a little bit more off to the side, of course, which in turn changes the tracking of the whole knee, the kneecap itself. So you see here we have a medial point and we have a more of a lateral point here, with the kneecaps tracking a little bit off to the right or off to the left. So what we're looking for is this nice tracking mechanism. If you have a congenital issue, quite often one of the possibilities is what they can do is actually go in and cut this off here and then move it over, right? So they'll move that whole thing over and reattach the patella tendon here so we get a nice vertical tracking point. That might be pretty aggressive, but you know, in certain circumstances, of course, that may be necessary. The other part, of course, is really what we really encourage everybody to do, because I think this is a bit of an anomaly, not seen in most people. Trauma, I think, is probably the number one reason why we have this floating kneecap. And secondly, of course, is mechanical weakness, where having a very weak inner thigh, so this is your vastus medialis. If you ever look at a bodybuilder and just look at the inside of his knee, and you see that big teardrop muscle, that's a very exaggerated version of this muscle here. And for most of us, this one's really quite weak, and of course we're very tight in the rectus femoris, that hip flexor muscle, and we're very dominant and very strong in the lateral part of the thigh. This is of course the vastus lateralis, and of course the IT band also attaches here. So when you have the tendency where this is weak and all this musculature is tight, our kneecap actually starts tracking again a little bit out to the side, which creates a lot of that discomfort. So part of the challenge, and why we admonish you to slow down and think about what you're doing, is that we wanted to retrain the knee joint so that we get this firing action or this reaction where these muscles contract in symmetry or simultaneously. So when they contract, the kneecap is pulled in a very safe vertical fashion, and it's not moving all over the place. So if you have something congenital, this is something that, of course, you're going to have to work with a physiotherapist on to see exactly what you can do. But of course, I would imagine, other than using various braces to help sustain that alignment, you can do a lot of work on really making sure this muscle is strong. So you really want to keep the kneecap pulled in and sustain a neutral position. So when you're training, in your various training programs that you're going through, really pay attention to that alignment. And again, if you have a knee problem, you don't just have a knee problem, you have a mechanical flaw or a mechanical issue. And seek out a physiotherapist, have it looked at, have your knee joint stability looked at, look at the tracking mechanism, the tracking mechanism looked at, and the likelihood for a lot of us, unless it's trauma, very unlikely it's congenital. It's going to be a massive weakness here, an exaggeration of the strength in the lateral part of the thighs. So hopefully that helps, and just one more bit of knee anatomy for you to pause over, and yeah, hopefully it helps.